Welcome to the urinary system. This is part one. This will deal with the anatomy. And so if you're in your lecture manual, of course, right there at the start, then this is what we're going to go over. So right now, what I want you to do is look at the picture that you've got there, that first page. I've got the diagram right up here, and we're going to go through this. You've got some labels that I want you to just add some extra things to. So let me look with you on here. And first of all, of course, you can see the kidney. You can see this kidney and this kidney, and right now I want you to tell me which one of them do you think looks lower? Okay, and so maybe you've already made a decision. I'm going to put this one up and let you look at this. Is one of these looking lower? And then I'm going to have you look at the model, and we'll see on here. And so as you look at this one, let me just bring this over. And when you look, here's the top of this kidney, and here's the top of this kidney. So if you thought the right one was lower, you were right. Now I'm just going to put this up so that you can see this is why. And so when you look at this, you can see that the liver is above this right kidney, and the liver is going to displace this downward just a bit. What does this have to do with anatomy and the kidneys? When we think of this, I want you to, right now, feel for your kidneys. So if you'll go back here and find where your floating ribs are, then between there and your iliac crest is where part of the kidneys are. The other part is going to be underneath the floating rib. There's not a lot of protection there, and that's why they say no kidney punches. And what would a kidney punch do? How much blood is going to the kidney? And when you think of it, 20% of the blood in the body is going to the kidney at any one time. So every 5 minutes, all the blood in the body goes through your kidneys. So if we're on here for an hour, then it's gone through your kidneys 12 times. So keep that in mind, because when we get to filtration, we'll see that again. Now, another thing that I want you to think of with the kidney being in that not so protected location, but a little bit of it, I want you to just, I'm going to mention an account of a young student, and he was in grade 8. He just come back in from noontime, and somebody pushed him, and he actually fell against a garbage can, a metal garbage can. And before school was out that day, his kidney had been removed. And so we can see that a rupture can happen, and if it does, there's a tremendous hemorrhage going on. Another account of a young fellow who was about 15, and he was riding in the back of a pickup truck and hit a bump, and he was thrown out, hit a rock as he landed, and he didn't make it to Calvary. He died before then. And so if the kidney is damaged, that is a lot of blood that's going through there, and that's what we're seeing. Now, I want you to think as well, I'm just going to move this so that we can see the diagram again, but I want you to look at the adrenal gland. And what does adrenal mean? So let me just get this. Now, as you look at the term adrenal, and I'll put it here so that you can see it again. Of course we know what renal means. It means kidney, but what does add mean? And add means additional. And so we've got, it's an addition to the kidney. It's not affecting the kidney as such, but it is sitting there. This is what we see for the adrenal gland. Now, for this, I want you to notice for the kidneys, obviously they're bilateral. We can see the two of them. When we used to go to the cadaver lab, there was a lady at one time who had what was called a horseshoe kidney. And this was very unsuspecting. They did not know that she had a horseshoe kidney. And when she donated her body and they opened up her body, there was this horseshoe kidney. It became something that people from numerous universities came to see. I'm just going to draw a simple diagram of what it would look like so that you can see that it was on one side, and so this is what it would have been. Now, there were two ureters, but this was a horseshoe. It had not separated into the two. And so then it was, as I say, just spectacular to see. And they saved it for years, and we saw it. Now, normally though, this is how it's going to be. And I want you to think as well, what about a transplanted kidney? Where would they put it? If a person needs a transplanted kidney, then it's not like they've got to have these kidneys removed. Where will they put the transplant? And if you just put your hands on your iliac crest, then right down in there, in the pelvic region, is where they would support it. I'm going to pull this over just so that you can see where it would be located. So they'd sit it right down into here, and then of course hook it up so that it's there. It would give it support, and that's the big thing that would be needed. What do we have for support for the kidneys as we have them here? There's a fat pad that's there, and in the textbook you'll notice the term perirenal fat capsule, and it gives cushioning for the kidney, but it also helps hold it in place. And so if you look here, you can see, of course, that these are coming down as normal, but there is a term called ptosis. Now, you might automatically think, oh, I've heard of apoptosis. And when you do, think of that. What did ptosis mean? It means to fall down or to droop. So if someone is extremely malnourished, doesn't have the fat pad, then there is that possibility that this kidney will kink down. And with that, then the fluid in the kidney, the filtrate in the kidney would collect, and the kidney would become enlarged. And so that term, I just want you to be aware of as we go through this. Now, the next that we're going to look at here, I want you to look, and you can see, of course, this one is lower than this one. But also as we look at this, then where is the hilum? What is hilum? And you'll recall we've seen the hilum in the spleen, the hilum in the lung. Now we've got the hilum here, and that's the location right there. That's the hilum. And so it's the central location where the ureters, the renal artery, renal vein are, and those are coming in and out at that location. So that's what we see right here. Now, where is the hilum on us? And right now I want you to just go to your umbilicus, and when you go there, that's the level of the hilum. Now you're probably familiar, we did cisterna chyli and said that was the level it was at. And what was the level? And maybe you remember, it was at L2. What is L2? Remember, it was the second lumbar. So that's the level that we're talking about. Now I want you to go from here, go to your umbilicus, wrap around right to the back, and of course, when we did the 9 regions of the body, those are the lumbar. And so that's lumbar, and this is second lumbar, and that's where this is located. So this is what we've got for location. Let's go into the notes just again. I want you to look for the ureter. You can see the label for it. And here we've got the ureter. How long is the ureter? And they will say 25 centimeters, 10 inches long. That would be the length for the ureter. Now, the next that we've got on the diagram is the urinary bladder, and you can see it just at this location right here. I want you right now to think, what kind of epithelium is in the urinary bladder? So, got an idea? All right, I'll give you a choice. Is it stratified squamous, is it transitional, or simple squamous? And I'll bet you chose transitional, and that was right. And so here we've got transitional epithelium. What does it do? It can expand and stretch and yet still keep the urine from seeping out. So that's what we've got right there. Now, how much fluid can go into the bladder in an adult? And we'll see this on a following page, but right now I just want you to think how much can go in there. And generally they'll say 700 to 800 milliliters. And so this is what we're looking at right here. That's, of course, for an adult. Now, the next thing that I want you to look at is the urethra. And You can see the urethra on the diagram right here and on your diagram in your book. I'm just going to erase a couple things so that you can see this better. And as I do this, I want you to think there are two sphincters, and one's called internal and one's called external. And so let's look at these and see. I'm going to just put them in red here so that we can see these. And here we've got the internal sphincter. Now, if there's an internal, we know there's an external. And I'm just going to put the external. Actually, I'm going to erase this down a bit. We'll put external right here. And then we've got external sphincter. Which one of these is going to be smooth muscle? Which one's going to be skeletal? And it turns out this one is the smooth muscle. And of course, that means this is skeletal. Why smooth muscle? Why skeletal muscle? When there's sufficient fluid in the bladder, urine in the bladder, it will stretch. And it will cause a stretch reflex, and it will actually relax the smooth muscle. At that point, you've got one sphincter left, and that's the skeletal that you've got control over because it's voluntary. And so this is what we see. Let's move on to the right side of the diagram. And on this side, you can see renal artery and renal vein. And I want you to think of the position for the kidneys in relationship to the aorta. Now, where's the highest blood pressure in the body? And obviously, we know it's the aorta. So then, are these in close proximity and able to get high pressure in order to do filtration in the kidneys? And that is very important, that they're located close to a high pressure area. And so the renal artery, the renal vein. On here you can see the aorta going, and then inferior vena cava as well. So those are straightforward. Let's move down to parietal peritoneum. And so for this one, I'm just going to use this. And I want you to recognize when we talked about the three cavities in the body, then we talked about, I'll pull this over for a second, we'll just look at this right now. And of course, what was this cavity, what was this cavity, and what was this cavity? And so we've got thoracic cavity, abdominal cavity, and pelvic cavity. But what was the division line between the abdominal and the pelvic cavity? Parietal peritoneum. Where's the parietal peritoneum? It's coming down over the bladder in male and female, and also over the uterus in the female. So down over the top and then back up. What did parietal mean? And it meant wall. And so here we've got the wall, just as you would have thought, and it's this. But as we look at this, I want you to put that parietal peritoneum and recognize then that this is below. This is inferior to the parietal peritoneum. I want you to look at the flaps. And the flaps here, as we've got, are to prevent backflow. Why would you want flaps to prevent backflow? And as this bladder starts to fill with urine, is it going to press against the flaps and prevent the backflow? But why? And so I want you to think of this situation. Could you get an infection in the bladder? And yes, you could, and that's cystitis. Would it be a more serious infection if the bacteria traveled up to the kidneys? And that would be definitely worse. And the term for that is pyelonephritis. The one for this is cystitis, and we'll see that as we go through, but I'll just mention that right now. Now, as we look at this then, the flaps are going to prevent backflow. But what's this opening? The urethra. Now, I want you to look at this, and what this little location is called, as you look at it, you can see it goes in a triangle shape, and it is called the trigone, which just means that it is a triangle shape. What is this for? As far as knowing what the trigone or where it is, it gives a map for the bladder. So if someone were to say, well, there is a tumor and it's on the right side of the trigone, or it's on the superior edge of the trigone, you know where it's located. So we've got that as map location. Now, down at the bottom of that page is pyelonephritis. I'm going to put this term right here. I want you to break the word down, and I'll just erase this right here. And so, of course, what's itis? Inflammation. This would be kidney, but what's this term? And so when we look at this, this actually means pelvis, and this would be kidney. And of course, we've got inflammation. But what is the pelvis? And if we go to this area right here, this is called the pelvis of the kidney, the renal pelvis. And the term also is pyelo. Pyelo literally means trough. And so this is what we have. Why would it be called a trough? Because it's a collection area for all of the urine that's coming in. And so as we look at all of these renal pyramids that are here, and the urine is being produced, it's going to collect and eventually collect into this pyelo or pelvis, and that's the area that we're looking at. Now, I'm going to just leave that, and let's go over to the following page. This one, the anatomy of the kidney, I've got the diagram right here, and as we look at this one, I'm just going to erase a couple things. Now, when you look at this, and as you look, I'm just going to highlight this. I think that will be a little more visible. And so as we look at this, you can see the kidney itself. And we're going to go, first of all, as you look, we've got the renal pelvis or sinus that we've just talked about just a moment ago. And when you look at this, here is the renal pelvis. And as we know, sinus means a hole, a space, and so we've got the renal pelvis. On your diagram, if you look, you can see the ureter. I would like you to put a kidney stone in the ureter, so I'm going to extend this down just a little bit here. And now when you make it, if you'll just make it a bit jagged, and so here we go, here's the kidney stone. Now let's look at the term kidney stone, nephrolithiasis. What did nephro mean? Well, it meant kidney. But what does lith mean? Stone. And so we've got a stone. Possibly, you remember back when we talked about gallbladder, and there was cholelithiasis, and that was gallstones. But here we've got kidney stone. What would a kidney stone cause? Well, besides pain, hematuria. So I want you to put this term down, just right here. And we're going to look at this, because the kidney stone, as it tears away at the inner lining of the ureter, it's obviously going to cause hematuria. What is hematuria? And this would be blood in the urine. So this is a big indicator, plus the fact that they're in extreme pain. And so here we've got hematuria. Let's go back to the diagram and just go through the parts that we have. And first thing, if you've got a red or blue for some vascular things, you could put that out in here. And if you recall, recall when we did the anatomy for the kidney in the lab, then you could see all this red and blue latex that was out in the perimeter. And that's what we made. It looks strange, but that's what we've got right there. And this is the cortex. Now the cortex, if you'll notice on yours, you've got renal cortex right there. %98 of the blood is in the renal cortex, so that's why we put this red in, because it's indicating that. And so we've got a lot of vascularity in the cortex. What does cortex mean? And literally, it means bark. And bark, we'll see it on the next page as well, but this just means it's the outer covering, and so we've got the cortex. Now, the next thing that I want you to look at, of course, is a nephron. And you can see this little nephron. I'll erase these so that you can see this. And now, as we look at this for the nephron, would you please also put how many nephrons there are in a kidney? And possibly, you might remember or know, there's 1 million nephrons per kidney. And so these, where you've got nephron, and I think I'll move it over this way just a little so that we can see this. So here we've got nephrons, 1 million of them in a kidney. And what are they called? And so we're going to look at that on the next page or two and see cortical and juxtamedullary. And so when we did the nephron in the lecture manual, that was juxtamedullary. The next that I want you to notice is the term minor calyx. And when you look at this word calyx, it literally means a cup. And so when we're looking, and you can see the cup shape here, those are minor calyx. Where's the major calyx? It would be here. So a number of minor ones make a major. Here's another major. Here's another major. How many of these renal pyramids have we got? So you've got renal pyramids on your diagram as well. And when you look at this for renal pyramid, would you please notice that it says there could be 8 to 18 per kidney. Now, what's a renal pyramid? And a pyramid, of course, is that triangular shape. And so when we're looking at that, there's a pyramid. If we were to count these up, let's just count together. So we've got 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11. So we've got between 8 to 18 of these renal pyramids in a kidney. But where are the renal pyramids? They're not in the cortex. They're in the medulla. And so where you've got a renal pyramid there, would you please put in the medulla? So now we've got all these pyramids in the medulla. What's happening in the pyramids? And that's where all the collecting ducts are. And the collecting ducts, of course, are collecting the urine, and then it's going to go into the minor calyx, into the major calyx, into the renal pelvis, out through the ureter. And so this is what we're seeing. Now, for the renal pyramids in the medulla, then after that, it gets into the collection areas, and that's what we see here. Now, let's leave that diagram. At the bottom of your page, on that page 56, you can see the diagram of all the blood vessels. I'm just going to show those to you on this model. And so, as you look at this for the model, I want you to just realize that out here are the arcuate arteries. And then in here are interlobar arteries. And so it's really straightforward. As we look at that, you can see arcuate over the arch, interlobar meaning between the lobes, and so we've got interlobar, we've got arcuate, and this outer cortex where the majority of the blood is, and that's what we're seing. On this model as well, I just want you to recognize the same thing that we just discussed. And so as you look, you can see here's a minor calyx, minor calyces all along here. Here would be a major, and of course you can see the pyramids on this diagram. Cortex, as we said, medulla here, and then this would be the collection, the renal pelvis or renal sinus. So we've got all of these before it drains into the ureter. On this model as well, you can see the renal artery and the renal vein. Now, for this one, I'm just going to bring it over for a moment, and you can see, of course, the adrenal glands on the top. And then you can see that the right kidney is a little bit lower than the left. And we've got that renal artery, renal vein, and that's pretty much got it for the blood supply on this one. Now, over to page 57. So if you'll go to that, we're going to look at this. It's a lot of this that we see, we've talked about. So let's check. What size is it? And of course, lots of things are compared to your fist size, and this one is as well. And so on here, you can see the size there. Why is it retroperitoneal? What does retroperitoneal mean? So I'm going to put the term just right here. And of course, you probably thought retro means behind. And so we've got retroperitoneal. Why would it be an advantage for the kidneys to be retroperitoneal? Well, I'm going to pull this over, and we'll just look at this again, and let's see what we've got. As you look, where was the peritoneum? It was against the wall and over the top of the bladder, but it sits over top of the kidneys. They are retro, they're behind. This is an advantage for a couple of reasons. One is they're not as affected by an infection that's going on in the peritoneum. And the other thing is that it helps to hold them in place against that fat pad that we were discussing. So they're retroperitoneal. That's what we see right there. Now, the next that we've got in your notes, it says on C, so for B, it's the spread of infection. That would be what you'd fill that in right there. And the next that we have for each kidney contains about, and of course, how many nephrons were in a kidney? And we said 1 million. And so put 1 million down there. And then on D, where's the hilum? And I bet you remember, the hilum was at the level of L2. And so we've got this. Now for E, each kidney is, the left kidney is under the spleen. The right kidney is under, of course, the liver. And so it is, of course, lower. Renal cortex, and we said it meant bark. So if you'll put bark right there, that was what cortex meant. Renal medulla, where the renal pyramids are, the renal pyramids, the cone-shaped areas that we've got, the renal pelvis or sinus, the central collecting area that we've seen right here. And so that's the next one. Renal artery and renal vein. Would you just notice it's close to the high blood pressure aorta, which is important because it's got to be able to do the pressure filtration. So it's got to be close to the aorta. For K, I want you to think what percent, as it says, what percent of all the blood flows to the kidney every minute? Anybody remember what that was? And if you thought 20%, you were right. Is this a lot of blood going to the kidney? And then, as we can see on the next line, every 5 minutes, all the blood in the body flows to the kidneys. What happens when you're exercising? If you're doing something endurance-wise, would all that blood go to the kidneys? No, it's not. In fact, that's a big concern with people who are doing some kind of extreme event, that they might not urinate for hours after the event because the body hasn't been sending the blood there. It wasn't the imperative thing that the blood went to the kidneys. It was needed to go to the leg muscles at that time, or for the endurance. Now, the drainage of the urine within a kidney, this is pretty straightforward. Let's just look at this briefly. For nephrons, would you underline that 4,000 nephrons drain into one collecting duct? So that's a lot of these that are collecting in. I'm just going to have you look at the papilla. And for this one, I'm going to just going to put a quick diagram of a nephron. And so here we've got a nephron. And when we look at this nephron, we said there's 1 million of them in a kidney. But what is this area right here? This is where the urine is going to drain out. This is the papilla right here. And the papilla then drains into the minor calyx, and the minor calyx drains into the major calyx, and the major into the renal sinus, and then into the ureter. And that's what we see in the just the list that you've got right there. Let's go to the ureters and check those. And how long were they? And so when we talked about the ureter, this was the 25 centimeters, 10 inches. And so that's the length of the ureter. Type of epithelial lining in the ureter. Anybody remember that? What kind would be in the ureter? And actually, it's the same as in the bladder. What type was in the bladder? And there we had, I'm sure you remember, transitional epithelium. So we've got transitional epithelium in the bladder and in the ureters, and actually in the very first part of the urethra. And so this is what that kidney stone was tearing when it came down through there. Now, for the next that we've got, I want you to look on B, the smooth muscle to contract and move the urine. What is the term for contracting and moving? It's the same as in the digestive system. And when we were doing digestive system, we said, what is the action that's moving things distally in the digestive tract? And of course it was peristalsis. So if you'll put right there, and so we've got peristalsis. The next one, if you'll just read with me on C and D, peristalsis occurs in waves and empties urine into the bladder about every 30 seconds. And so this is interesting as you look at this, and then the mucosal flap opens to let urine into the bladder and closes to prevent backflow and infection. Now, urinary bladder capacity, and again, maybe you remember what was the capacity for this, and of course, we said 700 to 800 milliliters in adults. Of course, in a newborn, it's going to be extremely small. And so we're going to talk about that in just a moment. Let's look at the next. For the histology, and you know this, and so I just erased it, but we had this. This was the type of epithelium. So transitional epithelium there. And involuntary smooth muscle in the bladder itself. Where is the bladder located? With respect to the peritoneum, where is it? I'm just going to pull this back just for a second so that we can see this. Where was the bladder located? The bladder was here, and so it was under the peritoneum. So if you'll put under the peritoneum, that's the location that we have there. The next, would you underline on C where it says internal iliac artery goes to it? Maybe I'll pull this back just again so that we can see that internal iliac artery. And as you look at this, I'm just going to bring it close here, and you can see here is the internal iliac artery, here's the internal iliac artery, and of course it's going to the bladder. Now, we need the term cystoscope, and I want you to look at this term. scope. And we know if you're looking in a microscope or a scope of a gun, it's to look. And so here we've got the to look, and this is the bladder. Cyst literally means a sac, but in this case it's the bladder. And so we've got the cystoscope. The next that we've got, along with looking inside, they can take a biopsy. And so they can take a biopsy as well as look inside. So if they're looking to see if there's bladder cancer, they could actually take this biopsy. Let's go to cystitis. Now that you know what this means, it's not tricky to know what cystitis means. So what's itis? Inflammation of the bladder. And that's what we see right there, inflammation of the bladder. And would you please notice, of course, it's much more frequent in females. 40% of all females will get cystitis. And as we'll see in just a moment, that reason is because of the short urethra in the female. Now for the urethra, the length in the male, you can see 20 centimeters. And then would you put where it says the blank, would you put prostate gland? And so here we've got prostate gland. It surrounds about an inch of the urethra. And in males, by the time they're 60 or older, it's starting to get bigger. As it gets bigger, it closes down the opening of the urethra, and we'll see on the next page, it can cause retention of urine in the bladder. And that's what we'll be looking at shortly. Let's look for the next, just indicating that urine and semen are conducted through the urethra, but at separate times. The internal sphincter closes, and as you can see, it closes the outflow from the bladder during ejaculation. In the female, it's just 4 centimeters long, very short, and cystitis is more common due to the shorter urethra. Then it says easier contamination with certain bacteria. The bacteria that are very common, would you put E. coli? And so this one right here. This is from the external area around the bladder, or for the urethral opening, and then it gets into the bladder and causes cystitis. 2 sphincters, and here the internal, would you put involuntary? The external is voluntary. And of course, internal is smooth muscle, and external is skeletal muscle. Now, if you'll turn the page, we're going to look at terms that are used for the action of urination, and you can see micturition and voiding and urination all are the same. For this one, I'm just going to have you notice in the notes here, and it says in an adult, the stretch receptors are stimulated when the bladder has 250 milliliters. So if you'll put 250 milliliters right there, that's what we've got. So once there's 250 milliliters of urine in the bladder, it's actually going to set off a reflex that will relax the internal sphincter. Now, let's read on. And for this one, it says, the stretching causes a reflex involving the parasympathetic nerve to the sacral region of the spinal cord. It causes the internal sphincter to relax. So the internal sphincter right there. Now, for the next one, it's talking about the fetus. And for this one, the fetus forms urine by 3 months, and urine is voided into, and I'll write this up here, so the fetus is urinating into the amniotic fluid, and we've got that one, and it helps maintain the proper volume of amniotic fluid. Infant has no control over micturition, and if you've been around a newborn, you would be familiar with that. but it has reflexive voiding when the bladder stretches. Now, when you think of that tiny, tiny bladder in a newborn, it doesn't take a lot of urine to cause that reflexive voiding. And so then, as we look at the rest of the statement here, it says, an infant's bladder is small and its kidneys are unable to concentrate urine for the first 2 months. So for the first 2 months of its life, it doesn't have concentrated urine. And then it has voids 5 to 40 times a day. So here we've got this 5 to 40 times a day. So reflexive voiding, it's going to do that. And of course, its only diet is liquid, and so it's going to have a lot of that. Let's go to disorders with micturition. Would you underline retention and underline, of course, the next one, incontinence, and check these. For this one, as we look at retention, I want you to read with me. It says inability to urinate. So urine stays in the bladder. It's common after general anesthesia. And so I'm just going to have you put some other causes down. One of the causes would be tumors. So as we look at this, you can see, of course, a tumor could close it off. Scarring could close it off. This one, BPH, benign prostatic hypertrophy. It's not malignant, it's not cancer, it just comes on. A male ages around 60, it will start to have hypertrophy. This is going to close off the opening for the urethra, and then retention could occur, and they may need to be catheterized to actually allow the urine to be drained. The next one, for incontinence. And for this one, as you can see, there's no control over emptying of the bladder. And so causes for this one, would you put stroke? And I'll put this up here. Pregnancy, definitely, there's pressure on the bladder. Another one, Alzheimer's. Got those. There is a term called functional incontinence. And what this means is the person knows they need to get to the bathroom, but it is hard for them to be mobile enough to get there quickly. And so they might have a walker, they might have a wheelchair. This would be a problem. And so I'm going to just, another one that we're going to see is stress incontinence, and I'll put that one here. And for this one, running, coughing, sneezing, dancing, it can put stress on and actually cause emptying of the bladder, or at least partial emptying. And so incontinence that's there. Another one, treatment of stress urinary incontinence. Now, in our society, lots of women living older, and with that, there's the big concern of incontinence and how it can be socially hard for them to go out because they don't want to be embarrassed. And so one doctor in Sweden had actually decided that he was going to do something about this for his patients. And he was a gynecologist, he was concerned about this, and along with that, he said, let's just put a band in the urethra. And so he did this, I'm going to just draw a brief diagram that you can see the anatomy of what was done, and so then you can see what was happening. Now, this has been in place about 17 years or so. He initiated it, and of course then other countries used it as well. And some people, 85 to 90% of them, actually it helped out immensely. And so let me just draw this quick diagram. I'll talk to you about it as I put it up here. Now I want you to think of the anatomy of the uterus in relationship to the bladder and the pubic arch. So there's the pubic symphysis. And then here's the bladder right here. So there's the bladder. And here is the uterus. And so there's the uterus right there. What he said was, what if we put a bend in the urethra? And so this is what the surgery did. I'm just going to draw another diagram and just put a bend in the urethra. And so here we've got the pubic symphysis. And now I'll put just a red tape around here. He anchored it to the pubic bone. They say the surgery is about half an hour, and what they do is do it under a local anesthetic so that they can advise the lady to cough so they can see that the tape is tight enough. And then that's how it's done. So let's read about it. And so as you look, you can see it's called the urethral support sling in females. Incision made into the vagina, secure the sling around the urethra and anchor it to the pubic bone. Put 30-minute surgery, and then put 80 to 90% cured, and the rest had great improvement. Put along with that, would you please put the note, use local or spinal anesthetic. And so I'll just put this here. So as we look at this, use local or spinal anesthetic, have the patient cough, ensure the tape is tight enough. And so this Swedish doctor obviously had come up with a solution which has been well used. Now, let's go on to the next. The function of the kidneys. Why do we have kidneys? And so as you look at this, you can see the list that we've got, 8 things here at least. Regulate the volume of water, definitely. The next one, maintain the solute concentration of blood plasma. I want you to think what the blood plasma concentration is. And when we did the nephron, we saw it was 300 milliosmol. So I'm going to put that right here. And so we've got, that is to maintain it for us. The next one, regulate the concentrations of various ions in the extracellular fluid. Even small changes in potassium ions can be fatal. Now, we know that hyperkalemia can cause cardiac arrest, and that would be what could happen if this occurs. And so the next one, would you underline acid-base balance? And I want you to think for a second, where are kidneys in the acid-base balance line? First, second, third, where do they fit? And of course, they're third. And so, third line of defense. Is there another one after that? Nope, that's it. And if a person is into kidney failure and the acid-base balance is now not controlled, in 5 to 7 days it can be fatal unless they get dialysis. And so this is big that they have this, the kidneys doing the acid-base balance. The next one, excrete metabolic waste, drugs, and toxins. And the sixth one, produce EPO. And what's that to increase the amount of? And of course, red blood cells. And so here we said, what percent of erythropoietin was actually released by the kidneys? And you probably remember 90% from the kidneys. Let's go to the next one on number 7. Produce renin if the blood pressure is too low. Why does the kidney need to have a good high blood pressure? Because it's going to do pressure filtration. And so it's imperative that it has a high enough blood pressure. Renin will be released if it doesn't. Let's look at this word, renin. And as we look at it, we know, what does IN mean? And IN means protein, but what does this part mean? A renal protein. And so here's that renal protein that's going to make sure that the blood pressure is high enough to do the pressure filtration. And the last one there, convert vitamin D to its active form. Let's go to the nephron. Just a couple things left here, and then we'll be finished up on this. So let's do this. The nephron, number of nephrons per kidney. I'll let you tell me. So what was the number? All right, good. 1 million? Hope so. That was it. 1 million nephrons per kidney. Now, if we read on here, it says, with age, about a quarter of these degenerate. This stresses the body to keep up with electrolyte, pH, and fluid balance. Are people who are older more at risk for problems with electrolyte balance or problems with controlling the amount of fluid in the body? And so now let's look at this next one, types of nephrons. Would you underline cortical and juxtamedullary? So we're going to look at these. In the textbook, there is a picture. I'll just put the reference up so that you can look at this. For the old book, it's page 968. And for the new book, it's page 981. Now, as we look at this, what are cortical, what are juxtamedullary, and if you're on that page by now, then you can see the cortical right there. Would you please put for cortical 85% of all nephrons? They originate in the outer 2/3 of the cortex, and the loop of Henle, or nephron loop, barely extends into the medulla. Now for juxtamedullary, what did juxta mean? Next to. So this is next to the medulla, and of course put 15% of the nephrons are this. Now you've got a little space right there beside this information, and I'm just going to have you draw a diagram just quickly. I'm going to use red and green for the colors. I'll put the cortical in green and the juxtamedullary in red. So let's look at this right now. Now, on your diagram, I'm going to, as I say, I'll put juxtamedullary in red. It has a long nephron loop, and so for this one, it's going to originate here, and then it has a long nephron loop. And so juxtamedullary, this one. So here we've got juxtamedullary, and you can see it goes way down into the medulla, and this is going to concentrate the urine. Now, the next one, for the cortical nephron, you can see in your textbook diagram, that nephron loop barely goes into the medulla. So out here, there's cortical. Nephron loop just barely goes into the medulla. It's originating from the outer part of the cortex, and now we can see this right there. Now, I want you to look at your information right here. On juxtamedullary, 15% of the nephrons originate in the inner 1/3 of the cortex. Would you underline they do most of the work of concentrating the urine? These are the ones that if it's a desert animal, it's going to have lots of juxtamedullary nephrons because it's going to concentrate that urine until it hardly puts out any water at all. These have long loops of Henle or nephron loops that extend into the medulla. Now that gets us through the anatomy for the urinary system. We are going to get into the physiology of it in the next video and check that over. So good luck with the studies, and I will keep in touch with you. All right. Thank you.